I'm Kate. I'm speaking to you from Toronto, Dish with One Spoon, Wampum Belt Territory, Treaty 13. And so grateful for that lovely introduction and for the opening in a good way from Elder Henry. I really needed to hear that today, and maybe you did too. And I want to recognize and acknowledge Indigenous health leadership as really paving the way and demonstrating what's possible for millennia, and also in the recent generations where Indigenous health leaders, including many of you who are here today, are really teaching the rest of us how to do this in a good way and what we can do, even with the challenges that face us in terms of structures, legislation, and history. So by celebrating and scaling community leadership in mental health promotion, what I really mean is I'm going to be cheerleading for you today. I am here to be your biggest fan. I'm a huge fan of community leadership in health, in upstream health promotion. And as a health geographer, the theme of changing landscapes and being changed by landscapes is very dear to my heart. So I will be, I really encourage you to please use the chat all the way throughout. I noticed that on Zoom, the chat, the membership list, the attendee list is in alphabetical order by first name. So I encourage you to, send a direct message to somebody who's just above you or just after you. They might even have the same name that you have. Reach out and make a new relationship, make a new friend while we're going, but also use the chat box to interact with me, ask questions, share your comments, critiques, concerns, and so on. We will have some time for a Q&A at the end of my talk today. And there will also be a breakout room afterward for people who want to keep talking. So just to reinforce what you've already heard this morning and what you know well, health happens in relationships. And I mean this in the most literal way possible, that we are constantly in dialogue with our environments, constantly trying to come up with an active balance between what's happening inside our bodies and what's happening outside our bodies. Homeostasis, right? This is like grade 9 biology. We are always in this dialogue. So we're in dialogue with the ecology and land around us, with our histories, with ourselves and ideas, with other people, with access to power and resources, with the systems and structures around us, and so on. And so we literally embody our social, political, environmental conditions. If we see a dramatic increase in challenges for youth mental health, this is a story. These young bodies and minds and hearts are telling us an important story about how we're doing as a society, as a culture, as care systems, as communities, as families. And we need to listen to these stories that these young bodies are telling us. And that's what you do. And that's what I'm here to celebrate today. As you know, most of our health is determined outside of medical and healthcare and clinical systems and in our communities, right? In socioeconomic factors, physical environments, things that we're able to access and do close to home, and so on. I'm not at the but yet. I'm going to tell you more about social. This is, we call this work the work of social infrastructure. Strong places, strong and participatory ways of being connected with those places, and connectivity through ability to access what's happening in those places. This is what fosters our sense of belonging, our sense of well-being, and our collective and individual resilience. And what we've seen, the data is very clear on this, that local places with strong social infrastructure, parks, libraries, health supports, schools, they outperform others by a long shot in times of stress. And we know we're in times of stress. There is real precarity in our world when it comes to geopolitics, when it comes to housing, when it comes to decolonization, and many, many other factors, climate change. We need to have strong social infrastructure in our communities in order to be able to weather these changes that are happening now and continuing to come at us, from wildfires to opioids and beyond. Here's the but. We still have a pretty static conception of what health is, and in particular, what health systems are. And again, I'm not talking about you in this room, you know, but you're encountering systems that we have inherited historically from another era, right? So health systems are very much still rooted in 19th and 20th century ideas of what health looks like. These are what the World Health Organization calls the 6 building blocks for what makes a health system, and they're pretty mainstream: service delivery, health workforce, information systems, access to medicine, and so on. This is a pretty old school idea of what a health system is and could and should be. And as a result, we see that less than 10% of health spending goes to community. Even community-based mainstream health activities, less than 10%. And all of that social infrastructure, the work of doing social determinants and environmental determinants of health, is still mostly disconnected from health systems. And we're still investing in the same 3 things that we've been investing in for a long time. So from the time of Confederation, hospitals and doctors, right? That's what in 1867 people thought made up a health system. Ignoring that this health system was designed with a very small subset of the population in mind, eliminating feminized labor in midwifery and other community health, eliminating Indigenous approaches to health and well-being, and so on. 100 years later, 1967, we finally added drug plans. Okay, so now we have hospitals, drugs, and physicians because we have Medicare. And I'm going for Community Health 2067. And you're laying the groundwork for that now by really expanding our idea of what health systems can be in the mental health promotion work that you are doing. So we still have these outdated health systems, and we're all trying to reform them from time to time, but we don't really question the boundaries of those health systems very much. We try to sort of maximize efficiency or impact within them. But it's relationships, right? It's relationships, as Elder Henry said, as Alice said early going in, and Colleen said, these are what really underpin health systems. So just one example is caregivers. If all caregivers took a week off, well, we'd experience the collapse of our health and care systems before noon on the first day. This is, again, feminized, racialized community labor that is absolutely essential to the sustainability and existence of health systems, economic systems, and other systems in our society, but we continue to pretend that it's not. But what if we didn't? What if we took a more realistic approach to what makes a health system and what really makes up our health? Certainly, the evidence has been there about social determinants, structural determinants, and so on for decades. And of course, we've known in human experience for millennia how important it is to be connected to land, community, ceremony, other people, and so on. But we've gone away from that. And, the professionalization of health and what makes health takes us away from the humanization and the reality of being on Earth systems and in landscapes in health. So this example comes from a paper that I really like called Beyond the Building Blocks. And really, it's by Emma Sachs and colleagues in the BMJ Global Health, if you're interested in having a look. It shows, though, in orange, those building blocks of the health system that the World Health Organization says make up a core health system. But it shows in blue what we could do if we considered community health as really a formal part of our health systems. Things like the household production of health, caregiver relationships, for example, those social and structural determinants of health, the work of community organizations like you, societal partnerships, community health promotion and healthcare services, community-based health workers, volunteer and paid. And we included that community stuff in information and in learning and in accountability. What would our health system look like if we took this seriously? That's what you're doing. That's how you are building toward a community health transformation by 2020, 2067, or even sooner. So again, this is starting to be recognized, and that's a good thing. So in the United States, for example, the Surgeon General, the former Surgeon General, really began to focus on loneliness and social isolation and how important relationships are for health and well-being. Again, individually and also collectively in a time of political and social polarization and disconnection. We need help. We need reminders. We need support. Even those of us who experience great white privilege, need a little bit of a boost to get back connected to basic relationships. Many of the structures that used to support our participation in our communities and societies just aren't as strong anymore. Faith organizations, for example, service clubs, other expectations to be out there caring for people day to day in our neighborhoods and in our communities. Here in Canada, the Public Health Agency of Canada's most recent Health Inequalities Reporting Initiative really focused on inequalities and thereby social and structural determinants of mental health in Canada. And that was a really important step, because it's a reminder and a counterbalance to the prevailing narrative that all our mental health originates in our brains. And it really looks to and describes the social and structural determinants of mental health and mental health challenges in our society for people who are facing exclusion, discrimination, history of colonization, precarity, right? Young people's precarious sense of their future jobs, future environments, and current lives, right? It's all of those kinds of social determinants matter, and it's starting to be part of the agenda more and more. And I should recognize here that the Public Health Agency of Canada is funding so many of you who are here today, and funding many of you also in a longer term way. So starting to get away from the precarity of funding for community-based mental health promotion and other supports is really what's needed to stabilize this work and make it available in an equitable way to all who need it across Canada. Again, this is being taken seriously worldwide. So the last two World Health Assemblies, one just in May of this year, one in May of last year, recognized both social connection and social participation, which means community governance, that we are involved in making decisions about our health systems, our health and well-being, and our communities. So it's becoming more and more part of the global conversation. Now, this is a simplified way of thinking about some of the ways in which social engagement can really help, right? So one of the ways that it can really help is that it brings us back to a sense of connection and safety in our communities. The further we are from feeling connected and safe and whole in our communities, the more we are likely to feel activated and aroused in our nervous systems, away from connection toward fight, flight, freeze, fawn, all of those emergency responses. And certainly we feel those even in our overworked workplaces or our overburdened home lives. And one of the ways that we can really bring ourselves back to health and healing is to be connected and to be in safety. I am a parent. I have 3 girls who are school age. And we've had a long year this year. One of my kids has been through a long health issue, and one of the other kids has really faced mental health challenges and anxieties as a result. And one of the things that really has helped is just being a regulated body, sitting next to a dysregulated body, and coming back to connection and safety. And this is something that you are doing in the work that you're promoting in much more sophisticated ways, but in embodied, real, and relational ways. This is what it's about. It's really about mattering. In healthcare systems, the clinical focus that we have inherited continues to be what's the matter with you. In the work that you're doing in health promotion and in the work that I do in social prescribing, we try to change that conversation to what matters to you and how can we help. Often people do need to address something that's very important to them before they're ready or willing or able to address something that's important to their healthcare providers, social care providers, communities, and others. For example, we worked in a community where older adults weren't attending to all of their medical appointments. And when asked why, they said it's because they needed pet sitting. And providing that pet sitting, providing support for those relationships with their pets allowed them to have the freedom to participate more in health appointments and also social life. And so in asking what matters to you, we are also flipping the script to show that you matter. This is not a message we hear very often in our lives, particularly in very bureaucratized and very technologized environments. We don't feel that we're seen or heard. We don't feel noticed. We don't feel nurtured. We don't feel needed. And I'll talk more about being needed and having something to offer, because in my view, that is one of the key things that's going to be important for all of those people who are involved in the programs that you offer. So it's about health promotion, and it's about self-determination, autonomy for individuals and communities to make decisions for themselves. Competence, being reminded that we are capable, we can do something, even if it's something as simple as making a piece of art, that we have a sense of accomplishment, and reminds us that we can take more control over our health and the conditions for our health with support sometimes. Belonging, you know a lot about this, mattering in your community, being recognized, having a sense of relatedness and relationship. And then giving back. So in many of the studies around social prescribing and social participation, it really is those people who have an opportunity to volunteer or share a smile in a space who report the biggest improvements in their health and well-being. And it helps us to create a sense of meaning and purpose again in our work, in our participation as participants, clients, patients. I like to say participants because it helps think about our engagement in a co-determined and co-equitable kind of way. And then it is that work of co-creation where we equitably and in a meaningful way share decision-making power. We decide together what matters and how we're going to take action on it. And we don't have people provide services at us. So that, in a nutshell, is really what social prescribing is. And so I'm going to make a little pitch that I think a lot of what you're doing is very aligned with, if not identical to, something we're calling social prescribing, which is in some ways just an umbrella term for addressing health-related social needs by connecting health and community services and using language that meets healthcare folks where they are. So instead of calling it community participation or asset-based community development, or many other languages that people use to think about this work, especially on the community side and health promotion side, the word prescribing helps to invite healthcare folks in a way that they understand and respect and could imagine themselves being a part of. So it's a systematic referral between health and social and community services that's deeply co-produced by people and communities and helps build that self-determination. And it can be on a range of different kinds of matters for different populations and can look really different in different places. And it's a way of really helping to link up clinic and community. And if you're interested in hearing about my story and the story of some of my kids and how it links in with social prescribing, you can look up this this piece that I was invited to write for Maclean's magazine earlier this year, The Case for Social Prescribing, where I talk a little bit about what our experience was like. And the mini version is acute healthcare saved her life, my daughter's life. But it was social supports from pet visits to an in-hospital school to gardens to support for us as a whole family that really made her life worth living again. And that kind of support, deeply available in hospitals, was a lot harder to come by once we were returned back out into community. And that's for somebody who works in this space and knows about it. We have a lot of work to do to make that more available to everyone. So we can do things like strengthen our support networks, come up with a shared language for evaluation and learning so we can talk about our shared impacts, to redistribute shared resources more effectively, in other words, give more power to community, invest in that local social infrastructure that we really need in this time, in this pivotal moment, improve our health experiences, our health outcomes, our use of health services. I'm sure you're finding this in your work, and definitely we see this in social prescribing, that people feel better, they enjoy their experiences with systems more, and they tend to use our very pressured and stressed and stretched health system resources less when it's appropriate and when their needs are better met elsewhere. And really importantly, it can look different in different settings. So it's adaptable for where you are, who your population is, and what's strong with you, and where you can start. And then I think, again, importantly, it's making the lives of health systems and health decision makers easier. in sharing that story in ways that they understand and respect. So some of the language that I'm using today might not resonate with you, but it does resonate with people who give you money and support the systems that you work in. And so that's some of the reason why I use the words around prescribing and medicine and so on. So it works like this. Someone who has a health-related social need is identified. Healthcare people don't need to know what the need is or what to do about it, but just notice that, for example, somebody keeps coming to their clinic and has a need that they just can't help given the clinical training and time and resources that they have. They can refer to a community person, a link worker, a community connector, a community health worker, someone who's more like a peer, who has more time, who can build trust, who ideally is of the community and can really listen and take the time that's needed to build trust and build a relationship and work together with the participant to help make a plan and maybe help them follow through on that plan. So then they connect, they actually participate in something from gardening to housing support. And the link worker person, again, might go with them the first few times until they're comfortable and able to go, addressing barriers to participation, addressing what really matters, and helping move people along. And I'm just sharing an image here from a new project about social prescribing for paramedics that's being undertaken by Healthcare Excellence Canada right now, just as an example to show that this can happen in many different kinds of settings. And community paramedics are in people's homes, in the living spaces of underhoused people, and can really meet people where they are. And I'm such a fan. I had a really close look at many of the projects that you have been doing, and I love them, and I want to celebrate and sort of mention a few of them and how they're doing this kind of work, and you are doing this kind of work already. So sometimes social prescribing work and mental health promotion can focus on specific populations and cultures and lands and languages. And so we see examples here of the Cedar Path, for example, and of Nurturing the Future, really focusing their work on, populations facing specific barriers and populations with specific strengths to offer to the community, and really developing with that area of focus. Some of you are focused on specific interventions or prescriptions. What are the things that people want to access? Maybe it's food. Maybe it's arts, right? Maybe it's nature or many other kinds of interventions. So some social prescribing interventions really focus here on what it is what we're strong with and what we have to offer to people, where we know there's excellent evidence for the health promotion benefits of these kinds of supports and services. Many of you are involved here in early intervention and prevention, upstream either in time. You're all really upstream in time in some ways, getting to people when they're young, preventing challenges from getting worse, instilling positive mental health structures and supports early in life, or maybe early in your experience of being here in Canada as newcomers, for example. Many of you are focused here on relationships, and I love to see it. I think that in youth and pediatric populations, we are better at this than we are for other age categories across the life course. We know that kids need their families and caregivers and guardians and communities around them. And I certainly experienced that as a parent as well, with kids going through healthcare and health system challenges. So you've got supporting different kinds of parents. You've got supporting different kinds of kids and families who are in transition with respect to gender identity, gender expression, and so on. And you've got really thinking deeply about early adversity and early relationships in life. I would love for that learning and that focus on people as being not limited to our individual bodies, but very, very deeply rooted in, relationship dyads, triads, and other kinds of relational ways of being in the world. That's just a reality that most health systems interventions do not address. And then many of you are also doing systems change, really thinking about things like putting more supports into the same physical spaces in a hub, or having teams who come together and try to address health and social challenges in a holistic and less disjointed kind of way that is more culturally aligned and specific, that's more place-based, and that's more appropriate for people instead of having them trying to navigate difficult and fragmented systems. And then also things like ensuring community systems of care, good pathways that help bring people together, whether it's under one roof or whether it's with teams that are not under one roof, but really collaborating and working together. And then there it comes back to that participation part that was so supported by the World Health Assembly, that we know mental health is shaped by our everyday conditions, and that participating in deciding what matters, articulating what's going on, sharing our strengths is very, very good for our health and well-being. And I'm really thrilled to see this kind of intervention happening through these funded projects as well. So a little bit more about the evidence. So I've been involved in a few different social prescribing studies, and I see in the list of who's here today that many other people here also have been involved in some of these. So one with the Alliance for Healthier Communities, the community health centers in the province of Ontario, showed, big decreases in loneliness, improvements in mental health and social activities and social participation, decreases in ER visits, general physician visits, and costs to the healthcare system. So that is talking about the evidence in ways that communities understand and care about, and also that providers and systems and funders care about. And we can share the qualitative components of that as well. It changed my life, says someone. And certainly that's what keeps me going and keeps me happy and optimistic in this work. It's just that the results are so dramatic. And if we saw similar results from a prescription drug, we would be floored. These results are amazing. And I really want to encourage you to keep sharing the results of the work that you're doing. And it works. So that's what we're finding. We worked with KPMG, which is a healthcare consultancy and management consultancy group worldwide, who found through an economic analysis that every dollar invested in social prescribing, and I would include your work into this umbrella, returns $4.43 in the form of improved social and economic participation and reduced healthcare costs. If you want to know more about this, the website socialprescribing.ca has lots of good fact sheets, including some related to children and youth mental health, as well as healthcare landscapes. You can find out more, take them to your local decision makers, and share the what's what. Okay, so how do we know? How do we realistically know that that's true? Well, we try to be part of learning systems. Sometimes those of you who work with healthcare systems, they call these learning health systems, but that work often is limited to quality improvement within an organization. So I like to think about it as learning health policy systems, where we learn in dialogue and collaboration with all the relevant interest holders, those policy and decision makers, implementers and systems folks, researchers, but also community members and community organizations, all coming together early on to say, what is it that we need to measure? What matters? What matters to us? How can we collect and evaluate and do this work in the most feasible, minimum viable product kind of way? And that's hard to do in community, but not impossible if we focus on what really matters most to all of us. And then we continue that cycle of improvement. And that helps us take our first steps too. We don't have to have everything perfect right off the bat. We have to take a first step and keep learning and keep getting that feedback and growing. And when it comes to the work that you do, I'm sure this has been the experience for many of you. It's positive feedback that makes you want to take that next step and know what that next step needs to be. So over the last while, I have been thinking a lot about that shared evaluation and what we need to be doing together and working with stakeholders, interest holders, including Healthcare Excellence Canada, to help us think about really shifting to that strengths-based approach from what's wrong to what's strong. And I've really lately been distilling it down to these 4 questions that can guide evaluation locally and shared evaluation, and really be layered over top of the evaluation metrics that matter to you. So it's not meant to be a replacement, but it's also not meant to be overly onerous. But some questions, binary questions, yes, no questions about how we're doing. Are we taking an appreciative and strengths-based approach led by people and community? Let's have a conversation about how we're doing, find some evidence to support our expert assessment as different people around the interest holder table, always trying to have some way to demonstrate the evidence, but really assessing just using our experience. Are we doing that? Are we transferring power to community by hiring local people or shifting funds from big institutions to small organizations or sharing governance? Are we improving public systems and shared goals? Those are those things around healthcare efficiency or making life easier for very stressed and burnt out healthcare providers and so on. And are we being a learning health system? Are we being inclusive and focusing on feasible and useful evaluations? If we ask ourselves these 4 guiding questions as we go along, we will be well on our way to having a better sense of how we're doing individually and collectively in trying to make a difference. So this kind of work is really growing here in Canada and all around the world. And we've got Canadian Institute for Social Prescribing, big investments to the south with Social Prescribing USA, and many others. So we have, if you're interested in seeing what's happening in your province or territory, check out Social Prescribing in Canada 2025. If you are connected with other countries around the world or curious about how people are making it happen where they are, you can look at the document that we're also part of, Social Prescribing Around the World, put together by the National Academy for Social Prescribing in the UK and the International Social Prescribing Collaborative or Collective, one of those. So yeah, we're continuing to draw attention and funding. I did a small piece of work with an organization here in Toronto called the Bentway, which is really trying to use public space as a way to create sense of belonging, mattering, healthfulness, and how simple it all can be. People told us that what they needed to feel that they belonged and mattered and could build connection there was a place to sit and some greenery or some intentionality around feeling part of nature there. So again, really simple stuff. We've got work, and I know Dr. Nicole D'Souza is here today, working on how social prescribing can combat winter blues, but also other mental health challenges for post-secondary students, starting at the University of Toronto's 3 campuses, but lots and lots of interest from across the country where campus health and well-being services are really aware of the need to help better support young people who, in theory, have access to many kinds of supports and services and beautiful spaces on campuses, gyms and libraries and clubs, but again, need help connecting to what matters to them. And we're also starting to see it on the healthcare system side. So, for example, the HSO Health Standards Organization is updating the primary healthcare services standard. So for all primary care all across Canada, and in really thinking about this community-led work, including the work of health promotion and social prescribing as a basic expectation for what happens in primary care. And it's being taken seriously also beyond that. So the Commonwealth Fund, which invests in this Harkness Fellowship, is a really mainstream health organization in the US that's taking this seriously and going to help take this globally as well. And the Hill Times invited me to write an op-ed recently, and I encourage you to check it out because it really is about how our moment, meeting our big moment here with respect to trade relationships with the US and other big geopolitical change. It's about a lot more than, how we make and make stuff and sell stuff and buy stuff. It's about those strong local communities that can be resilient through the work that you do. And the reason that that's of interest and that you should all listen up for this part, because Mark Carney has promised $4 billion in community health infrastructure. And I'm really arguing that needs to go beyond just clinics and hospitals, but to that broader social infrastructure, because so much of our health is really being built in the community through these social supports and upstream mental health promotion services like the ones that you do. If you want to get started with social prescribing or maybe formalize the work that you're doing that's already essentially social prescribing, here are some of the steps. Find a way to connect in with health or social partners. Think about what is available and strong in your community and really start there. Bring everyone together from the beginning or early on to think about what matters in evaluation and how you're going to do it. You can repurpose or train people to play that link worker role. You don't necessarily need new funding. I would never argue against it, of course, but there's a lot we can do with the strengths we currently have. And again, start small, using feedback to learn and grow from where you are. So at the Canadian Institute for Social Prescribing and in the broader work that I do about community-led health and well-being. We're really in this space in the middle here where it says help it happen. We can't over-plan or over-regulate, over-manage, or over-engineer in a recipe-based way how this is going to work. It just doesn't make sense given the diversity of health and well-being and our lives in a big country and lots of different kinds of health systems and so on. But we can't be totally just letting it happen to us either, because then we're not really shifting that power and moving toward the health system we want and need that really reflects our bio, psychosocial, political, economic reality. So how do we do that? How do we do that negotiating, influencing, and enabling in the middle? Well, we try to do things like neutral convening and relationship building, not competition. And again, that can be hard for community organizations who are, pushed into systems where they have to compete for funding. But really taking the time to get to know one another, and through the work of organizations like the KDE Hub, who are bringing you together to build bridges. Authoritative, but also rapid evidence generation, right? Not letting the perfect be the enemy of the good, but really using what we know now and continuing to learn and grow. Providing useful tools and supports for people, taking a strengths-based and optimistic, but also feasible approach. And again, really thinking about the right systems conditions rather than the recipes in complex adaptive systems. Here's the conversation guide again, just as a reminder: strengths-based approach led by people and communities, transferring that power to communities and local areas. Yes, improving systems in ways that are meaningful to the people we work with and collaborate with, and being together as we learn. So when we're thinking about helping it happen, not making it happen, not letting it happen, but really helping it happen, this is something that I use a lot in my teaching about health advocacy. And I would say that probably many of you are very good at the policies, practices, and resource flows part of advocacy. We know what policy change we needed or practice change we needed or how much money we need. You're also probably not too bad at the transformative change, mental models, right? Especially those of you in academia. Let's think about it from a completely different paradigm. And over time, people have increasingly been more attentive to power dynamics, and I see that reflected in the work that you do. One area where people don't tend to do as much, and you do, and I really want to celebrate, is around relationships and connections. We've talked about that already. That approach is also really important in advocacy work. So not just in the work you're doing with people and communities, participants in your programs, but getting to know decision makers in your area, getting to know journalists, getting to know other people whose work is similar to yours or could complement yours. Those kinds of one-to-one relationships, they matter a lot. And I think in much of the work of health, there tends to be often an overemphasis on the individual level, right? Individual people encountering healthcare, or the population level and the big P, public health, and policies that need to change, and not enough attention to the meso scale, what happens in community. And seeing the work that you're doing in community-led work really is heartening for me, because that's the part that's missing, and that's where you have something really strong to offer. So I really want to encourage you to lean into that relationships and connections part of what you do and apply it outwardly as well as inwardly to helping people to learn about what you do, to be there and available as experts when decision makers are looking for advice, to be the person who comes to mind, the organization who comes to mind when they want to make a change. So think about that as you go forward. So as I wrap up, I really want you to encourage you to think about one of these areas. It doesn't have to be the relationships and connections one. It can be any of those where you think your program has a big impact on health. What's something that's concrete and high impact that you could do more outwardly to advance this work today? What matters to you here? Why does that matter to you? Why might it matter to someone else outside? And keep it as brief as possible, because we want to get this moving and we want to get it moving yesterday. Write your answers in the chat and we'll see and be encouraged by how people are doing it or could be doing it or have been doing it in the past. I think I'm at just exactly the right amount of time. So I'm going to stop there and open it up to a conversation with just some of my superheroes, who are those of you who are here in the room today. Thanks so much for having me with you.
Thanks, Kate. So I'm going to just jump in because I did see a couple of comments and questions come in through the chat. So Pema was resonating with the anatomy of dysregulation figure, and I saw some hearts. So I think that one did resonate with folks in attendance. And Michelle Lorette was reacting, I believe, to when you were describing how social prescribing works. They were saying that this is a great way to avoid re-traumatizing people by not telling their barriers and struggles over and over. And then Alina wrote that they love all the angles you're coming at, and that they are deeply interested in thinking about what radical rationality looks like, not just in healthcare, but in all policies. So that's the first question. And I see there's another one from Jonathan after that.
Radical rationality. I've never heard that before, but I love it. I think, oh, relationality. Okay, well, I'll go into both of them. Radical relationality. So, first of all, radical rationality. I mean, sometimes we're over rationalizing and we think we're only operating from brains and not bodies and places and relationships. On the other hand, I think sometimes it is radical in our community spaces to be the one to say we need to have evidence that matters and is meaningful to others in ways that are meaningful to them. So sometimes that rationality can be helpful too. Okay, radical relationality. Isn't it weird and hilarious that that's radical? Because from my perspective, and I think many of yours, that's just a fundamental fact. It is a fact of our biology and our lived experience on planet Earth that we're in relationship with things. And even if we have a more sciencey way of talking about homeostasis or breathing or other things that we do that interact with the world, it's just a fact. And so I think that really embracing that, whether it appears radical or not in the spaces that you're working in, is really liberating. And so I really do try to take that matter of fact tone when I take this work into spaces where maybe they're not as accustomed to talking and thinking about relationships, because everybody has those relational experiences in their daily lives. Like we come from families, we live in neighborhoods, we take buses, or we have all these times when we're bumping into the world, and we. It used to be difficult to get people on board with the idea that social isolation and social connectedness and belonging, for example, were profound and meaningful determinants of health. But as soon as we all experienced isolation during the COVID pandemic measures, it became very easy to do. And so sometimes there is that gap in lived experience, and that's a way. That's another place where you can tell really strong and important stories from the work you do, the places you work, the people you work with, that kind of help us to gain empathy for other people's lived experiences when they're not shared by, more privileged or more cloistered decision-making people.
Thanks, Kate. So I think we might have time for one more question, and I'll just go in the order that it came in. So how does social prescribing factor the availability / accessibility of linked services? What is the cog in the wheel at the moment? So Jonathan is saying they're imagining it's not just one answer, and that linking people to existing services, increasing capacity of existing services, or increasing new services might be part of it. Or does social prescribing also include advocating for gaps in services?
Yeah, that's a great question. Our colleagues in the UK often call this too many travel agents and not enough holidays, that we can't just set up link workers if there's nothing to link people to. We know that the community services sector is underfunded and precariously funded. On the other hand, it's much stronger here in Canada than in other places. So I just spoke to urban libraries from across Canada and the US earlier this week, and there is a huge gap between what we have and what they have. We have more. We have a stronger social safety net. So I like to start with that strengths-based approach. It will be a nice problem to have if and when we get to that challenge. But again, this really speaks to the importance of measurement, evaluation, and learning. So, I don't want to impose evaluation expectations on community organizations that are strapped for no reason. But there is a reason. And one of the reasons is that it helps us identify in a very precise way where more investment is needed. So you might have heard of precision health, and people are talking about genomics and very tailored high-tech interventions for people. Well, this is precision community health. So we know at the population level that housing is good for us and food and so on. But we actually have very little data about what happens when one specific person is referred to a program about housing or food or arts participation. And what does that do to their health experiences, their health outcomes, their use of health services? And so when we can really start pinpointing it, then we'll be able to have it at that neighborhood scale, exactly where we need to make more investment and intervention. And along the way, we will have been building relationships between these organizations that and sectors that might not have been collaborating as much before. It will, in the end, I think, require well-being budgeting by governments in a way that, you know, different ministries and departments aren't competing about funding, but really thinking about their collective shared pot of money together. So that's a big part of it too. So yeah, it's definitely a concern people have. We have not encountered it yet in social prescribing, and so I'm encouraging us to just keep going, keep learning, and we will get more feedback as we go about how to address that in precise ways.